echocardiography for congenital heart disease, the difficulty is knowing what to leave out, because obviously echocardiography is a very big subject in pediatric cardiology. It's of much more importance to us as cardiologists for children than it is in adult life. And for surgeons, it's also very important because in many cases it's all the information you're going to get. So not only is it important for you to know the use of echocardiography, but it's also important for you to be able to understand the images, because if this is the only visualization of the anatomy you're going to get, then you have to be able to interpret themselves and therefore translate that into what you're going to see in the OR. Right, we'll start with the first slide, I hope. Okay. Now there are really three modalities of echocardiography that we use in pediatric practice. And the first is in terms of fetal diagnosis. Increasingly, congenital heart disease is recognized in prenatal life. It can be accurately diagnosed starting about as early as 14 weeks gestation, and it can be recognized up to term. And as the years go on, an increasing proportion of cases that are coming to us as infants are recognized prenatally. So we already have the diagnosis when the child presents in the delivery room. The next modality we'll talk about is transthoracic echocardiography. In neonates, it's particularly important in terms of giving us anatomic diagnosis. In children, for diagnosis and for follow-up, not only for follow-up pre-op, before surgery, but also in post-operative follow-up. Transesophageal echocardiography is becoming an increasingly important aspect of our practice. We only have had our transesophageal probes for a couple of years now, but now we're very reliant on it, and the very idea of not having the TEE in the operative room, the surgeons don't like that anymore. So we're committed to a lot of transesophageal echocardiography in the perioperative period. Transesophageal echocardiography, of course, is also important in the follow-up of children with congenital heart disease as they become adults. As the transthoracic imaging becomes more difficult, it's useful to be able to use TEE to image young adults with congenital heart disease. And just to put some sort of perspective of it in terms of numbers, in 1995, in the pediatric echo lab, we did about 5,500 echocardiograms. I haven't looked at the figures yet for this year. And about 3% of those were fetal echocardiography and about 3% TEE, although I did do quite a lot of fetal echocardiography in the obstetric department. Now, what are the implications of fetal echocardiography? Is this going to impact at all on your practice as a cardiac surgeon? Well, it may do, particularly in the future, as increasingly we're making diagnosis of congenital heart disease early in pregnancy, because some parents will elect termination of pregnancy for very complex forms of congenital heart disease or for forms of congenital heart disease that are associated with other malformations. So that may indeed impact on our practice as the years go on, and I think as we look into the next century, this will become have an increasing implication on our pediatric practice. The other thing that we can look at as pregnancy evolves is that we can see changes in congenital heart disease as the pregnancy evolves, and that can be very interesting in terms of understanding the evolution of congenital heart disease and perhaps thinking of ways that you could change this evolution in prenatal life. The other important impact is that for the lesions that are going to be duct dependent in the postnatal period, where the systemic circulation or the pulmonary circulation is going to be dependent on the patency of the duct, these patients should be delivered in a center where they are going to be able to be immediately taken care of. Prostaglandins can be started in a controlled way, and surgery can take place expeditiously if necessary. And the other lesions that are important to consider under the heading of important to deliver in a centre are things like the mixing situations, like transposition of the great arteries or total anomalous pulmonary venous return. So these are the kind of lesions where we want to deliver them within a cardiac centre. Now here are two examples of fetuses with congenital heart disease, where the parents, if they have the information about the congenital heart disease, might consider termination of pregnancy because of the disease that's present. In this fetus over here, the spine is posteriorly, the fetus is looking up towards us, this is the apex, and you can see in this fetus there's a large atrioventricular septal defect. And this is the lesion, of course, that's characteristic of Down syndrome. The other clue to the diagnosis in this particular fetus is there's a little pericardial effusion, which is a common feature of Down syndrome. And this fetus was detected as part of the 4-chamber view screening program, and the mother was 18 weeks gestation, the heart was examined, the abnormality was detected, she was referred for further evaluation, the chromosomes were analysed, and she had the information of Down syndrome prior to 20 weeks gestation at a time when she could consider interrupting the pregnancy if that seemed like the correct management for her particular family. This is another example of an atrioventricular septal defect over on this panel here. In this case, the fetus is lying with the spine up towards us, but you can still see well into the fetal thorax, and the apex is down here. Again, it's a common AV valve bridging an atrioventricular septal defect with an atrial and ventricular component. But in this fetus, there is what I would call right atrial isomerism. I come from a different school from Dr. Van Praag, whose members are just as persuasive as he is. So I think this is right atrial isomerism. The important thing is it's associated with complex disease. There was anomalous pulmonary venous return. There was asplenia, there was a common atrioventricular canal, double outlet right ventricle, and pulmonary stenosis. So a complex of disease that is a series of disease that is very complex in terms of the future. It's going to be a one ventricle repair, it's going to be a very complex disease, and this is another example of the kind of disease where the complexity of it might make the parents choose to interrupt the pregnancy. Now, the other thing we can do as pregnancy goes on, and has proved very interesting for us as pediatric cardiologists, is to observe how congenital heart disease can change as pregnancy goes on. These slides represent the same fetus. This fetus is seen at 20 weeks gestation on the left panel. The same fetus is seen at 32 weeks gestation. And here on the left side, what we see, the spine is over here, and what we were seeing was that the left ventricle was dilated, it was poorly contracting, the walls of the left ventricle were echogenic, there was a critically obstructed aortic valve. So this was critical aortic stenosis. But when we looked at the same patient at 32 weeks gestation, what we can see is the typical appearance of a hypoplastic left heart syndrome. Now the apex is formed by the right ventricle, the left ventricle looks like a little shrunken chamber, but in fact it measures exactly the same as it did at 22 weeks gestation. It's just that the rest of the fetus has grown, the left ventricle has stayed the same size because of the lack of flow through it, and the left ventricle has become a typical hypoplast, and at that stage there was aortic atresia. So the evolution of congenital heart disease, how it changes in prenatal life, has proved a very interesting understanding of how congenital heart disease in some cases can develop while you, at a stage in pregnancy, while you can watch it. Now, hypoplastic left heart syndrome is also an important lesion where you would want to deliver this fetus in the centre for where the surgery can take place. If you can prevent neonatal transfer, if you can prevent the child becoming very sick or becoming unstable in the first hours or days of life, then you're going to have the best results for Norwood stage 1 surgery. So this is an example of a fetus where delivery within a centre is going to be important. Now let's turn now to the use of echocardiography in congenital heart disease in postnatal life. And the first starting point is that you can get complete anatomical diagnosis, and this is particularly relevant in the infant. And you can see in this fetus, I'm always talking about fetus, but this is a child, of course, and what we're seeing is almost the whole anatomy on this single section. We're seeing that the apex points to the right. We're seeing that there's a common atrioventricular septal defect. We're seeing that there's double outlet right ventricle. We're seeing that the pulmonary artery is obstructed in the subpulmonary region, and the pulmonary artery itself is rather small. So this is a common atrioventricular canal with dextrocardia and double outlet right ventricle with pulmonary stenosis. So you can get complete anatomical diagnosis in infants. And this can help you to direct you towards the surgery. And here's an example where this echocardiogram is sufficient for the surgeon to be able to plan the surgery and understand the anatomy, sufficient for proceeding to the operating room without any further information. You mustn't forget that in the old days when we catheterized all these infants, and we didn't have echocardiography, and many of our young fellows have forgotten these days and don't realize that catheterization of the newborn is not without risk. Certainly 15 years ago or so, when I was a fellow, this was something that we had no choice, because this was the only way we were going to get the anatomical information, but it was associated with risk. So we want to avoid catheterization in newborns if we can get all the information we need from the echocardiogram. And here we have a nice echocardiogram that shows us the anatomy of an interrupted aortic arch. We're seeing the origin of this small aorta here branching into two at the top of the ascending aorta. Here is the descending aorta being supplied by the duct. So the surgeon has got to anastomose this point with this point here in this interrupted aortic arch type B. But the anatomy can be clearly displayed and allow him or her, if you have a female cardiac surgeon, that would be a nice change, to see the anatomy well and allow the surgery to be planned. Here are two other circumstances where the anatomy can be understood from the neonatal echocardiogram, and again will allow your surgeon to plan how he or she is going to proceed. And that, of course, is going to depend a little bit, in this case, on the surgeon. What we see here is the aorta lying anterior to the pulmonary artery, and we're looking for the coronary arteries. Our surgeon always grunts at us when we bother doing this and says it doesn't make any difference to him where the coronary arteries are, but we still like to look. And in this neonate here, what we're seeing is that there's an intramural coronary. Not a common form of coronary artery anatomy, but one that occurs in about 1 or 2% of cases, where the intramural coronary lies between the two great arteries and runs in the wall of the aorta. So some surgeons find this more difficult to transplant, and some surgeons would think this was an indication to alter their management to perform a thinning procedure instead. But the important thing is that you must be able to display the anatomy to your surgeon and allow him to make the decision or plan the surgery appropriate to him. One of the difficulties sometimes with complex cardiac anatomy is that the techs or the fellows get so excited about the complex intracardiac anatomy that they forget to look at what's important. And here's an example here where we had a newborn with complex intracardiac anatomy and double outlet right ventricle. Well, the aorta was arising from the right ventricle. There was no pulmonary artery arising from the right ventricle. So they'd come back from the floors with the echocardiogram, the ultrasound machine, and were describing the intracardiac anatomy to me. And I said to them, well, all that's important for this newborn is that he needs a shunt and what's the side of the arch. And of course they've been so carried away with the other things that they were looking at that they'd forgotten to look at that. But you must remember what's important to the surgeon, and in this particular newborn, all that was important was the side of the arch, so that the surgeon could decide which side of the chest he's going to open. This, of course, is very crucial, so they had to go back up and look for that specifically. And here you can see it looking from down below. Here's the aortic arch sweeping over to the left, and therefore the surgeon knows to go in on the right to place the shunt. Now, the next use of echocardiography is to provide adequate information for surgery in children. Now, in later childhood, not the neonatal period, but in later childhood, cardiac catheterization is safe. You're not wanting to, in general terms, you're not wanting to avoid it quite so desperately as you are in the neonate, or quite as importantly as you are in the neonate. But in many cases it's not necessary, and you would prefer to avoid this unnecessary test if you can. But again, you need to be absolutely sure of what you're doing and what you're seeing with the echocardiogram. Here we had a 6-month-old baby who was very sick, and we did want to avoid cardiac catheterization. And what we were seeing, and what we were suspecting as a diagnosis, because of the dilated, poorly contracting left ventricle and because of the characteristics of the EKG, we were expecting that this baby might have an anomalous left coronary arising from the pulmonary artery. But when we looked at the aorta in short axis, here's what looks like an absolutely normal left main coronary artery arising from the aorta, and it seems to breach the wall of the aorta at this point here. So it looks like a normally arising left coronary artery. The clue to the fact that it is in fact arising from the pulmonary artery is the direction of flow within it. The direction of flow in this coronary artery is in the reverse to what you would normally expect, and that suggests that it is in fact arising from the pulmonary artery. And at surgery, our surgeon told us that in fact there was fibrous continuity between the coronary artery and the aorta, but at this last moment the coronary artery turned directly posteriorly and plugged into the pulmonary artery. But it was a very difficult diagnosis to make. We were obviously very anxious that we'd sent this child to surgery with an incorrect diagnosis, because we didn't look forward to meeting our surgeon after he had found that out. Fortunately, it was in fact an anomalous left coronary from the pulmonary artery, but the clue was in the careful evaluation of the colour flow map. Now, here are two other examples of congenital heart disease where, if it's absolutely straightforward and uncomplicated, if the clinical signs and all the other signs are straightforward, there is no need for cardiac catheterization information, because it doesn't add to you the information that the surgeon needs. And here's an example, a complete atrioventricular septal defect in a 6-month-old child, or a 4-month-old child rather. 2 equal ventricles. There was very little AV valve regurgitation. There's nothing more you need to learn from the cardiac catheterization. So this kind of lesion can be corrected surgically without needing hemodynamic information. Similarly, this is an example of tetralogy of Fallot. In the uncomplicated case, there's no reason why this needs cardiac catheterization prior to surgery in our practice at least. Now, what about post-operative follow-up? Of course, once the surgeon's been in there, the anatomy is rather distorted. It's rather different from what you expect. It takes a little while to learn how different surgical techniques look. But here's an example of the use of post-operative follow-up. In this case, it's a post-mustard repair, where we have obstruction of the pulmonary venous atrium at the common site in the waist of the pulmonary venous atrium, where the pulmonary veins are coming into the left side over here, and they're baffled across to come to the tricuspid valve and right ventricle in order to exit the aorta. And here you can see not only on the 2D image but also on the turbulent flow across it on the colour flow map that there is some obstruction to pulmonary venous return post-mustard repair. Now, lastly, we'll turn to the use of the transesophageal echo. And as I've said, it's very useful for us to follow up adolescents and young adults who are less echogenic, who are less able to look with transthoracic imaging to be able to see the anatomy. So it's useful to use transesophageal echo for this particular use. But our main use for it is in the immediate preoperative evaluation in the OR to remind the surgeon of what he's seen at the cath conference in this particular patient, to remind him of the anatomy, to confirm what we've diagnosed on the TEE transthoracic findings, and to check some of the things that we're not so good at seeing on the transthoracic echo. And immediately post-operatively, it's important to evaluation of the repair, and that is particularly important in the setting of the valve repair or valve replacement, to look at patch integrity and to also look at function as the patient comes off bypass. We looked at a series of 200 TEs that we'd done over a 15-month period to try and evaluate just how useful it was in practice. And we found that there was only a small number where its use was critical. Its use was very helpful in 12. It was useful in 66, but we would probably have got the information in other ways. And there was no impact in the majority. But that's pretty good in terms of figures. That means mostly we're getting the transthoracic imaging correct. We've got the information before we go to surgery. And there are only a small number of cases where its use has been very useful. But that also reflects on your surgeon. In general, if the surgeon is good, then we won't have to go back and make changes to the surgery if we find something as we come off bypass. And here are two examples where TEE has been very useful. Here we're replacing a pulmonary band in order to prepare the left ventricle for a switch procedure at a later age. And here you can see when the band was placed at first, the left ventricle dilated, the function didn't look so good. As the band was released gently, the left ventricle became more responsive and was contracting well as a result. So just this little bit of adjustment made a difference to this patient as it was coming out of the OR. And here was a patient, again, this is not very common, but it happens from time to time, after repair of an atrioventricular septal defect. There was, despite the fact the mitral valve, or the left-sided component of the AV valve, had been tackled surgically, as we came off bypass we realized there was quite a lot of regurgitation from this AV valve, and the surgeon had to go back on bypass in order to re-repair the left-sided component of the common valve. Now this is rare, normally this doesn't happen, and it turned out some stitches had slipped on the valve, which were readily repaired. So the second time we came off bypass, there was very little mitral or left-sided AV valve regurgitation. But this is the kind of situation where TEE is going to prove very useful. So just to summarize then and to finish, echocardiography is a vital diagnostic tool in the management of children with congenital heart disease. If you're going to do the thing properly, you must have a wide range of transducers, both for prenatal and for postnatal study and for transesophageal study. And you're going to have the greatest accuracy if you've got a dedicated lab with high volume. Thank you for your attention.